Okay, I think we will start. And just a couple more people coming in. Okay. Good afternoon, everybody, and you're very welcome. My name is Eilish Paus. I'm a director in Grant Thornton, and I'm currently the acting chair of the Healthcare Committee. I'm delighted to host today's session. Thank you for taking the time to join us. Before we begin, so we have a few housekeeping notes. This webinar is being recorded. We plan to upload this recording to ActuView, and we will also share a YouTube link for any attendees who are not on ActuView. You can ask questions at any point. There is a Q&A box in which to type your question. And if you prefer to ask your question aloud, you can use the raise hand function, which you'll find at the bottom of your screen. And we will gather the questions as we go through the presentation, and then there'll be time at the end for questions. So we intend to seek accreditation from the LIA and the IOB. Once confirmed, the CPT codes will be posted on the event page, and this will take between 2 and 4 weeks. So please check back here to log your hours. So just before we kick off, I'm going to set the scene a little bit. So today's talk, we're talking about AI. It's transforming healthcare, but there's hidden biases in data and algorithms, and that can undermine trust and lead to unequal outcomes. This session will explore fairness in medical AI using real-world case studies and the XFAIR-MED, XFAIR-MED frameworks. You can correct me on that later, Ruairí, to show how bias can be detected, explained, and addressed. Attendees will gain practical insights into building AI systems that are not perfect, but fair enough to support safe and equitable decision-making. It is a pleasure to introduce our speaker, Dr. Ruairí O'Reilly, a fellow Corkonian. Ruairí is a lecturer in computer science at Munster Technological University, and he specialises in AI, digital health, and explainable machine learning. He has led and contributed to numerous interdisciplinary projects in healthcare, artificial intelligence, and has a particular focus on bias detection, fairness, and human AI collaboration. Ruairí is a senior member of the IEEE. He has published widely, co-chaired international conferences on explainable AI in healthcare, and is an active member of ADAPT and Lero research centers. His work aims to ensure that AI systems are transparent, trustworthy, and aligned with real clinical needs. Ruairí, thank you for joining us, and I'm going to hand over to you now.
Thanks for that, Eilish. It's great to be here, and thanks for everyone else who's attending. So again, I'm going to give a talk. It kind of covers different areas of my work. The latest piece is kind of a paper around the XFAIR-MED framework and some issues I see in enabling equitable AI for healthcare. So the title, fair enough, building trustworthy and equitable AI in healthcare. We'll kind of explore topics of that. And there are some limitations, which it's important to acknowledge, because I think that there's a lot of hype, a lot of excitement about the potential of AI. Sometimes that can be overstated. And there's also pragmatic issues with enabling solutions that aid healthcare. So just in terms of kind of boilerplate stuff I was given, all the views presented today are my own. They don't reflect any of you or your views, nor my employer. Okay, that's just a caveat. In terms of the competency framework wheel, I filled this out as best I was able to. And if there's any incorrect CPD or other requirements there, you can update it at a later date. Okay. So to start off, AI in healthcare and medicine, what are we actually talking about? Well, for me, it kind of works, well, disease identification diagnosis. We're kind of talking about classification, using our algorithms, our data models to help us analyze data. So again, medical images, genetic data, electronic health records, to help us diagnose and disease patients more efficiently and with improved accuracy than traditional methods. Now, you kind of move from that towards another aspect or caveat, which could be treatment personalization, optimization. And this is kind of trying to look at those data sets to see what's the best solution, not only for the ailment, but for you as the patient being treated. And how can we actually enable that such that not just a successful outcome, but an outcome that has less impact on your day-to-day well-being and your day-to-day state of life. And this is really going to be a growing area in the next number of years. Finally, we kind of another perspective will be operational efficiency automation. And this is kind of like enabling us to kind of enhance hospital clinical operations, manage patient flow, forecast demand for any of our actual services we provide, ideally while reducing cost and improving the overall patient experience. And like this really is kind of, in my perspective anyway, is moving from a narrow to a broader context. And what that kind of means is that this is the simplest layer in the sense that you have a well-defined problem, you have a particular ailment, and you have the data you gather with that ailment labeled. So now I can train a model that will mimic a clinician in a binary classification for does the patient have a condition or not. And that's kind of, that's the most common exposure to machine learning, for instance. While you move into a broader context when it comes to personalization, you're trying to broaden out your understanding. Now you're trying to understand a disease, how to diagnose it, the different drugs, the different clinical steps you can take to address that. But now you have variance. You have variance that comes from environmental factors, the population, from the access you have to these treatments, and you have different silos of data, which makes it much harder, but will lead to better overall results. You broaden that out again, and you're actually now talking about how do we actually operationalize any of these gains? And that's much, much more difficult because you're now constrained based on the health infrastructure available on a national or international level. Some hospitals will only have very limited consultants for particular specialities. So therefore you might be required to travel, and trying to enable that broadened context, really that's going to impact the rate of adoption of AI, and addressing the limitations of any healthcare system is inhibited by constraints at each level, which then will have a knock-on impact for the fairness and the equity of any solution you can provide. So I'm going to take a step back now and just kind of talk about conceptualization of AI and what I actually mean by that. So a good kind of definition for AI is from the engineer's perspective. So where engineering is seen as designing artifacts that interact with the world. And a definition for AI I like is from Russell and Norvig. They'll be big names in the field of AI, where AI operates the most interesting end of the spectrum, where the artifacts have significant computational resources and the task environment requires non-trivial decision-making. And really, it's this non-trivial decision-making that separates an AI solution from an engineered solution. Like a calculator is an engineered artifact. You input numbers, it gives you the answer. It knows exactly what to do. But when there's actually multiple different possible outcomes, how do you rationalize which is the best one based on the data available to you at any given point in time? That will push it into the non-trivial. And when healthcare is associated with that, it's important. Now, why do I emphasize the enabling XAI? If we want to have systems that enable us to perform non-trivial decision-making, and we want to provide those systems in a healthcare setting, we need it to be explainable. And explainable AI just refers to the concept that whatever AI model you're using is able to give you a rationale for the classification or output it's providing. The most basic form of that would be the use of interpretable models. But there's significant work going into the increased interpretability of deep learning models, which we'll talk about later on. And again, why do we want that? Well, we want to enable human AI collaboration. It's important. I do not think that AI is going to replace people. I think it's going to be a productivity enhancer. It's going to enable us to do our work more quickly. It will give us kind of a second opinion as to the quality of our work, and we will give a second opinion as to the quality of the AI work. And overall, we should focus on realizing those gains. Okay, so bias in AI in healthcare. What are we talking about? Well, again, for fairness and bias, they're very hard to define, is the first thing I would say. Like, what is fair? I mean, depending on where in the world you're born and where you grow up, you're going to be born into a different healthcare setting in the first place. If you're in Ireland, I mean, you have public health available to you. If you're from a very well-off family, maybe you have private health insurance, which again gives you other options to your healthcare journey. Okay. In the context of bias, how is that treated differently? If you can afford access to a GP, versus those who can't afford access to a GP as the first part of their healthcare journey, will AI compound that? Hopefully not. In terms of sources for bias in healthcare, from my perspective, data is kind of the largest. A lot of our data exists in silos. I mean silos whereby we're in the 21st century, and right now we don't have access to a electronic health record readily. And I can't easily share my data between different health practitioners. And we experience this on a day-to-day basis. For instance, I was bringing one of my children out to the Cork University Hospital for a checkup, where a consultant had made an appointment, but the pediatric unit had no record of this appointment. So I had to re-give the history, which, it adds a burden to our infrastructure where we cannot share data in a readily available manner. Additionally, the gathering of data, the normalizing of it, the standardizing of it, it's expensive, especially when it's not currently being done as a standard process. And there's a hesitance to fund both research and initiatives that enable that to be enacted. But hopefully, I guess people on the panel or people attending the webinar will give me insight to ongoing initiatives that will resolve that. In terms of algorithms and socioeconomic factors, this really depends on how transparent, how readily published they are, and how available they are. So again, if they're following a peer review approach to science, then you would publish your algorithm, your data that you use to train the algorithm, the results of it, and have follow-up on that. In the ideal world, that's the way it works. It can be more difficult in terms of, well, research institutions, healthcare providers, they are competing on some level. So it's a case whereby maybe you don't release all the data. Maybe you don't release all the caveats of the implementation of the algorithm. And I mean, that is in an academic or a researcher's self-interest, because I am competing with other academic and researchers in the same area internationally. Our work has to be peer reviewed, but I mean, that could be the deciding factor between me getting funding for my next grant or me not getting funding, So there is a bit of competitive there that can impact what is reported about the algorithm. And socioeconomic factors, again, different countries have different accesses to levels of healthcare. How digital and digitalized is that? Consequences for healthcare outcomes, I would say predominantly negative. Again, not to an extreme level, but I mean, they do have an impact. And we'll explore some of them in terms of AI. So I'm going to walk through a couple of case studies for where fairness and bias can impact it. And I guess it's important to note, I'm not trying to apportion blame to any one entity. It's just a case of where I see these arising. Okay, so some prior work. Diabetic retinopathy, okay? So it's a disease that affects your eyesight. It's classified using retinal fundus imagery, you can see here. And typically you have kind of a 5-stage classification of it, where you have no diabetic retinopathy, mild, moderate, severe, proliferative. Okay, and in the case in many clinical settings, you would need an expert clinician, so in this case, an ophthalmologist or some such, to actually classify these images to say what level of severity you have. And in almost all cases where you have clinical expertise, expertise is expensive. Because it's expensive, it's limited. Because it's limited, there's almost always a shortage of it. A hospital can't afford multiple. We can't afford 24/7 care. But that can be compounded. Well, that motivates the adoption of computer-aided diagnostics. So can I automate the classification process, maybe as a initial screening, such that we can train a qualified clinician to assist with the gathering of the data, have it automatically screened, and then given a certain level of priority based on the output of that model. Now, the issue with this kind of condition is that it is increasing, So the more severe the condition, the less data that will be available. So as you want to treat this as soon as possible, such that someone's eyesight is not worsening. But a consequence of that successful treatment will be that as you go up the severity scale, there will be less data available. A consequence of that is that it becomes more difficult to actually train the models to classify at a later stage of the disease itself. So how do you address that? Well, you need a larger pool of collaborators contributing the limited data they have to enable successful models to be classified, or trained and used as classifiers. So that's kind of an example of, it's not a bias as such, but because we're curing the disease at an earlier stage, we're limiting the impact we can have in addressing the problem at a later stage. And that's quite common in healthcare. Second example is skin tone bias in diagnostics. So this kind of relates to AI models trained to classify melanoma. It's one of the most common forms of cancer, so skin cancer. And an issue with that is the models underperform on darker skin tones. And again, that really relates to both the level of clinical research ongoing in countries with darker versus lighter skin tones, the parties who are willing to pay for the collation of the data. And this is kind of this is a major one that's often under-recognized in that, there's plenty of top quality research institutes all over the world. But quite often, the richer institutes, predominantly the US, will pay for the actual collation of data and make the data publicly available so that other researchers can then take that data and train their models. So for instance, if I put in a request to Research Ireland and a part of my budget, I'm asking for 100,000 to enable me to have this data clinically gathered, assessed and labeled, my grant will become much less competitive. So it's less likely to get funded. So often the richer the actual economy you're working with, and the more generous they are in terms of research funding, the more money you will have, and that contributes to why lighter skin tones are the predominant openly accessible data for training these models. Additionally, up until recently, the way this data was labeled, it didn't use so like this is kind of the Fitzpatrick scale for labeling the skin tone, but it would not contain that. It would contain a statement of racial background or ethnicity, which again was kind of pigeonholing people into their ethnic background and an assumption that the actual skin tone would match with that automatically, which is introducing what we now consider a bias. And the consequence of that, the models will underperform for darker skin tones. Now, people are working to address this, so that's not, but it's just an example of where a bias can come about. Okay, I'm just going to touch briefly on generative AI because it's a hot topic at the moment. So I'm going to assume that the majority of people on the call are familiar with LLMs, large language models, so your ChatGPT, or Gemini, Copilot, etc. And I do work with generative AI, but I would work more so with GANs, generative adversarial networks. And to my mind, LLMs have given generative AI a bad name because they hallucinate, they make up stuff, yada, 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 okay? While generative adversarial networks is kind of a game theoretic approach to the generation of data, and it's predominantly used for generating synthetic data where you have data shortages. So the two examples I gave, one in the context of melanoma and the other in the context of the retinal fundus imagery for severe PDR, You take that limited amount of data, you try and pass it to a discriminator. The discriminator's job is this data real or is it fake? And it'll say, oh, it's fake. That gives feedback to a generator, and you have this kind of min-max game in terms of trying to approximate the real data. Once you start approximating, you're generating very accurate real data. Now, very accurate looking synthetic data. So it's a way of enabling us to address those shortages of data for ailments that might be underrepresented. And it's a promising area. Some people don't like it, but if any of you have trained machine learning models or use machine learning in general, you probably will be familiar with the balancing of your training data, ensuring that each class has approximately the same amount of data per class, and utilizing that to ensure a balanced model at the end. To my mind, GANs has a lot to offer in addressing that in a superior fashion to traditional data augmentation. Okay, but that's just kind of my piece on generative AI, in case anyone is welcome at that. So back to data biases. So fairness and bias, again. So we're just going to define these so that we have the same kind of working assumptions. The principle that AI systems should perform consistently across different groups without systematic discrimination. And our bias, AI systems produce systematically prejudiced outcomes, often due to issue in data collection, algorithmic design, or the socio-economic context. Now, we spoke already briefly on the sources, and the example I will work for discussing the XFAIR-MED framework is breast cancer. So if we had a model for breast cancer, it could perform well overall, but systematically it could perform worse for younger women, for instance. Okay, why? Because in terms of the labeled instances of data where breast cancer occurred, they would be on the lower end of it. So they might be considered an edge case by the model. So then you train your model, you deploy your model, and maybe that has a higher misclassification rate for young women who have breast cancer, where it's giving false negatives. Now, that condition can be worsened or aggravated if you're then talking about younger women who are from minority ethnic backgrounds, okay? Because again, you're reducing the actual pool of data that correlates most closely with them. It's not the case in all scenarios that will have an impact. Depends on the test, depends on multiple other factors, but it's important that we look for kind of intersectional biases in our data when we're training our models and when we're evaluating our models, such that we don't have disparities in health outcomes and consequently have some groups getting delayed or incorrect diagnosis. And that's kind of the consequences we're trying to address, and we're kind of doing that by enabling a framework that simplifies that in the actual training of our models. So I'll walk through that. Okay, so the XFAIR-MED framework, really what we're looking for here is kind of it's a methodology that will allow us to kind of assess any biases, from a unified perspective. And we want to take multiple different demographic factors, and we want to look at them in the context of data fairness. So are we looking at our data from multiple different perspectives? Are we running appropriate tests to ensure our data is of particular standard? And are we publishing that sanity test along with whatever model we're outputting? Then we want to combine that with kind of algorithmic and model fairness, okay? So that's to ensure that whatever model we're using, it's how interpretable is it, and do any particular factors from the data we're using skew that model in a particular direction. In terms of entropy-based weighting, well, what we're looking for is, are there any impactful biases we should be aware of? And it's kind of we basically want to kind of like assign, relative importance to all the different fairness metrics we're using. So we can use Shannon entropy. So we're kind of quantifying unpredictability or variability for our metrics. Finally, we want it to be model agnostic. So for based on different type of models, linear, nonlinear neural networks, each of them will be more or less readily interpretable. If they are less, we want to record that, and we want to see how these different fairness scores are skewed by the application of that model. But I'll walk through each of these in more detail. Okay, so in terms of breast cancer classification, again, 36% of all cancer patients worldwide, approximately nearly 1,000 AI, ML medical devices in the US are currently in the process of approval or undergoing it. And that really brings up the question, what data were these models trained on? How specific were those demographics? Are they biased? If so, how do we tell to what extent? Now, we used a SEER dataset in our work for demonstrating this framework. It's 4,000 female patients, 16 features, and it includes age, race, and marital status. So and I will say it's very hard to find this type of data with demographic information. Again, that also wouldn't be a clinical priority in gathering it, or we'll gather some, so it will be an incomplete picture. So ideally you would have a much larger data set, but it is what it is. And then we kind of perform a comparative analysis of different models we're going to consider. So logistic regression for the linear, random forest for nonlinear, and neural networks as our deep learning approach. Okay. Now, these three will be particularly important in context of intersectional biases that we can uncover. Okay. So, intersectional fairness. What are we talking about? Interconnected nature of social categorizations such as race, class, and gender as they apply to a given individual or group, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. Now, again, if we can address these, well, what would the benefits be? Well, we would enable groups that are being mistreated in terms of the diagnostic capacity to be improved, or at least highlighted. I wouldn't even say improve it. Enhance model interpretability. This works two ways. This is kind of a case of enabling clinicians to trust the automated solutions that are available to them. And again, I have many thoughts that I could go on in this context for clinicians, but to kind of put it basically, decision support systems, which you're probably all familiar with, these can kind of be like rule-based systems whereby you give a collection of inputs and it gives you kind of an optimal output. They have been around since, well, they were kind of the follow-on from expert systems, which was a very hot topic in the 80s, leading into the 90s. And they've outperformed clinicians probably since the mid to late 90s for very, very narrow questions. So when I say very narrow questions, it's, okay, I have a patient who needs blood pressure medication. Which blood pressure medication should I give to them? So you enter the patient's data, you enter the medication I'm going to give, and it can optimize that decision-making process to say, no, there's a better variant for this particular patient. So sometimes clinical decisions, they could be kind of a suboptimal decision, could be 1 in 10. And all that means is maybe there was a slightly better medication. That's the kind of thing that a decision support system won't get wrong. If the data on which it's built is correct, then the decision will be correct. Now, if that has been around since the mid to late 90s, why haven't they been widely adopted? And this comes down to kind of trust. Trust, I would say, and liability, because the clinician will ultimately be liable for the decision that was made. Okay? And that's kind of a conversation for a different day and how you address that problem. But at least in the very first step, we should be enabling interpretability and transparency in any suggestion or solution we're providing a clinician. If we do not do that and do not provide the rationale for why we're taking a particular approach, then on what basis will they say this is a good or poor system that aids me in my day-to-day work. Finally, in terms of improving data representation and equity, this can kind of work both ways, because while a model could still be performant on ethnic subgroups, highlighting the different data proportion can motivate the collation of more data. So it's promoting gathering new data for particular parts of your population, which ultimately can be reused in addressing that. Okay. So again, the FAIR-MED is kind of broken down to two parts. The compound fairness score is overall, but we'll break it down into kind of a data fairness score is the first component. Now that kind of details a number of metrics we want to collect about the data we're actually using. So this typically relates to the training data that will be used in any machine learning model. And we have a number of different characteristics. So like representation ratio, standard deviation of the data. So like, how similar is it to the real data that we're actually gathering? Then we have kind of the maximum absolute correlation score. So that's kind of, is there any feature bias apparent across the features we're collating? Feature distribution weighted, again, so clinical variables, how are they distributed amongst the population we're actually considering? And then the intersectional imbalance score. So this is kind of telling us, what is the class imbalance on the intersectional level? So we kind of run through multiple permeations of the data to evaluate this, generate metadata, and then attach that to any model we will utilize going forward. In terms of algorithmic model fairness score, or AMF, what we're interested in is performance score, perturbation, and residual. So again, for performance, what actually causes disparities? And typically, we're looking for max difference in accuracy. In terms of perturbation, it's how sensitive is our model? So what will actually alter the actual outcomes of it? While residual score is the predictive effects, how many errors are introduced for different groups that we're actually considering. Now, again, I will give a link to the paper that will detail the implementation of all these in greater detail. But really, it's giving us more information about the data on which we're training and the model in which we're employing. So why do we use entropy-based weighting? Okay, well, I guess the intent behind this was kind of to highlight the benefits of data-driven approaches. So we want to kind of prioritize biases for interventions to maintain transparency and interpretability. So bring attention to that. So the intent is that it will ensure that metrics demonstrate greater uncertainty have a higher influence on the fairness evaluation. In practice, that requires a much more widespread evaluation of its utility. But utilizing that, the hope is that we enable transparent, interpretable, and data-driven bias prioritization. Okay, why? The data fairness score gives us the importance of different data and assesses all those metrics in each category. The algorithmic and model fairness score assigns weights to these metrics, okay, and tells us what impacts the performance of our models, what causes disparities, which group or subgroup will actually be most highly impacted. Okay, so in terms of like some results on that basis, I guess this is kind of the output it would generate. And I guess, it's not meant to be readily apparent to your everyday clinician how to use these, but this kind of information is meant to be published with any training approach or generation of a model for use in healthcare, such that those who are interested in it come check these numbers and see how appropriate was the implementation and training of that. So again, if we look at kind of, the different standard deviation of the values, so it kind of gives us an idea of how balanced are your actual demographics, okay? So again, the younger the patients, the impact it can have on that in terms of real data to the representation ratio and how low that is. If you move on towards the actual correlation scores, demographic values, and the target candidates, like you see what influences it, what's actually impacting it. And is it age, race, or marital status? And similarly, you're also looking at kind of the feature distribution scores, okay? And these kind of weighted based on, tumor size, survival months across racial groups, and you see, which ones are impacted the most. So other versus white, so again, for survival months, other versus white, and that's giving insight into the efficacy of this model for those who are not classified, okay? Okay, and again, for kind of imbalanced intersectional groups, like you're looking here at the combining the different demographic variables for the SEER data set. Again, you have your age, race, and marital status. And it gives us kind of an insight to certain demographics and the breakdown. So like again, 40 to 44, married. You have this IR up to 37. And like that's kind of showing extreme underrepresentation for mortality cases for that specific subgroup, okay? And your traditional or your standard fairness metrics would miss that. It wouldn't report that information, okay? And like that's kind of what we have the argument whereby intersectional imbalance is enabling real-world fairness, while it is also creating additional work for those people developing or deploying these models. So we really need to gather more data for this subgroup to enable a fair representation of it. In terms of the algorithmic and model-specific fairness, again, we kind of break this down into the performance score across the demographics. So in this instance, we're capturing model-specific accuracy disparities, and we can see that you're getting higher disparities across age and marital status, and so for neural networks, 0.127, while random forest 0.071 and logistic regression 0.060. So here we're saying that the neural networks can actually amplify bias, okay? The regression, it's more stable, while random forest, it kind of balances the performance across different groups. But then if you move on to kind of your perturbation scores for the different models, you're kind of saying how sensitive are any of these models to small changes in the attributes. And that's important for the trustworthiness and robustness of whatever models that we're producing is. So again, in this instance, our neural networks are indicating that they are the most sensitive, and you follow that on by actually, perturbing those scores across the models, and you see the neural networks having a major difference based on those perturbations. So as we're altering it, it can have a major impact on that model. And finally, kind of residual scores. So this is kind of like trying to quantify the prediction error and the disparities of the prediction error based on the different demographics. Now, in this case, random forest has the lowest and your logistic regression has the highest. So this is kind of indicating a limitation of a linear model. But what the residual score does is it highlights subgroup unreliability, and again, which is kind of a risk and fairness that mightn't be seen purely by evaluating the accuracy of the model. Okay, so like those two kind of give insights into data fairness and insights into the algorithmic model fairness. But we're trying to put them together in a kind of unified approach so that we can actually enable insight into actually how, well, we want to simplify the clinicians' work in seeing how well they work. So we use the compound fairness score as kind of a unified metric for assessing fairness. So it integrates the data fairness and the algorithmic model fairness to enable this. So we kind of use a harmonic mean formula to enable this. And like that means that any poor performance in either the data fairness or the algorithm will lead to a worse overall fairness score and indicate a need to address this. Okay. Now, overall, in this instance, the random forest achieved the best fairness while neural network was actually the worst, and logistic regression in the middle, okay? But your model choice will have a kind of a major impact on that. And I guess that's a lot of work for, say, an ML engineer or a clinical engineer working with someone developing an ML model. But it's kind of a key step in generating metadata so other people can come along and accelerate downstream research in terms of improving the approach you've taken, or implement and deploy a model, measure for efficacy of the model in a regulatory setting, or provide insightful interpretations as to why a model was good and bad in that scenario. Now, just kind of to summarize, we discussed the compound fairness scores, the data model fairness, again, the combination of that. Why is it good? Well, combining it, again, will accelerate research, also allows re-implementation of research, it builds trust in research. The intersectional bias and empirical benchmarking, this I think is important. And I don't mean that from the basis that, I think we are, I don't think we're being unfair or we are being biased intentionally. I think there are pragmatic reasons for these biases occurring, particularly in open research questions. Again, the main drivers of that are the availability of data and the willingness to fund the collation of data to a standard that will enable us to address those biases. In terms of empirical benchmarking, it's a key step for the enabling of the adoption of AI in healthcare and enabling equity in healthcare. In terms of what's coming next for this, we're kind of, I guess, an area, if you remember earlier, I mentioned the concept of personalization. So we'll kind of integrate genomic data into this approach, which will enable a much wider net in terms of different subgroups we can consider or have to consider, thereby increasing the actual complexity of the problem. But we're currently working on a proposal to do that, and then we will automate the integration of that into machine learning pipelines to assist additional researchers in this area. But yeah, look, that's kind of all I had to talk about for today. So if anyone has any questions, I was told to put this kind of indication for your raising hand icons, and happy to take any questions.
Thanks, Ruairí. That was definitely thought-provoking. Yeah, so as Ruairí said, there's two options. You can either raise your hand and ask your question aloud, or you can put your question in the Q&A box. I might just start with a couple of questions just to get us rolling. So one thing I was interested in was you were saying that some of this data is kind of openly available, which I'm kind of a little bit surprised for because, healthcare data obviously would have a lot of data privacy laws around it. So I guess to a certain extent, like, is it still useful or is it anonymized or aggregated or something to the effect that it's maybe not as useful as you'd hope?
Yep. Okay. So again, there's huge quantities of data available in health. It will all be anonymized, and typically it will have been collated as part of a research project. That could go from the tens of thousands to the hundreds of thousands to the multiples of millions. But part of that will be the sanitization of that data and the release to the general public domain, that's kind of a critical part of research in general, because we have to be able to take other people's data and validate what they're doing. I guess in relation to the issues with GDPR, absolute major barrier to healthcare. And I can give an example of this where, I was working with a conglomerate, I won't give any names, but they had divisions in the US, in London, and in Ireland. Now, the topic was very relevant to the entire organization, and they had teams working in the different localities. But the US was not willing to share the data with its Irish division, even though they're the same company, same employer, same everything, because of the legal ramifications of transferring the data. And that's within the same organization. And they have gathered this data, they've gotten all the sign-off from prospective patients for gathering that data, but it was a barrier to them. So how is a major conglomerate, if they cannot progress their own healthcare solutions because they are being tied down by these data silos resultant from the legal ramifications. I mean, if they can't do it, who can? You know, it's kind of it is a major barrier, and I'm not sure there's an easy solution for that. I would hope for an EU standardization of electronic health record or a standardization or some data sharing agreement as one potential solution. The other solution, which people don't like as much, is kind of where the company owns all the data. So again, a classic example, something I envision is if you're familiar with wearables, so like your Apple Watch or your Fitbit or your Garmin watch, like, give them access to all the data, allow them collate it, and they will enable a marketplace for people who will, provide arrhythmia detection algorithms, sleep apnea detection algorithms, and that's my one vision I would have. But we have to go one way because I think these are problems that can be automated and can be solved, but we need access to the data to solve them.
That's great. So we have a question in from Marion Keane. So she says, thank you for the talk. Outside of bias and fairness, what do you think are the greatest risks for future applications of AI in healthcare?
The greatest risks. Okay, well, a real risk is if it gets it wrong. Okay, and I mean, because whoever's on the receiving end of that misdiagnosis is in trouble. And I've seen multiple examples of this, not in the context of AI, but in the context of human-computer interaction. Two quick examples I gave. So for radiologists, when they're targeting a tumor for where to treat it, they would have a stylus and they would draw around the tumor. Now, that was implemented. If you did that in a clockwise fashion, it worked fine. If you did it in an anti-clockwise fashion, it totally messed up the computation of the actual part of the body because of the way the software was implemented. That took about 5 to 10 years to be recognized. I think it was used widely in Mexico and South America. So lots of people were being treated with radiotherapy in the wrong part of their body. And that will happen with widespread adoption of AI if it's not given proper oversight. But at the same time, I don't want it to be an impediment to the adoption because they should go hand in hand, whereby you should be incentivizing the productivity gains and reinvesting them in the oversight of the gains you're getting while providing the service to more people, to more efficiently, would be my answer. But yeah, there are 100% are risks, but that's it. No such thing as a free lunch.
Yeah. Well, I suppose this next question is quite interesting. It says, how has the research influenced your own interaction with health services or healthcare providers?
Oh, yeah. Look, in terms of interaction, peak and troughs, I mean, I can feel very positive and I can feel very negative. And it's like, honestly, I don't think that the majority of issues are technical barriers. I think there's socio-political barriers in terms of healthcare. And really, I guess, if I was to explain the concept of an expert, which is what your consultant level care is in any given capacity. If I'm in the CUH and I hire a consultant in whatever area it is, I'm not going to hire 2 or 3 that can do the same thing, okay? Because the cost will become prohibitive. So by that definition, there will be one in Dublin, one in Cork, one in Galway, maybe one in Limerick. Now I've dispersed my expertise so that they can't collaborate readily about whatever topic or field they're operating in. And for love nor money, I don't understand why we don't have where consultation and analysis can be provided remotely. So say particularly things like neonatal EEG data, you need an expert neurophysiologist. So you're really limiting the pool who can provide it. Why we don't have one European centre whereby it's offering 24/7 care for out-of-hours care for hospitals across Europe, charge a premium, but like have the data sent over, have the analysis sent back, And we can do that for multitude. The technology is there, the infrastructure could be there, but we're not doing it. And like that's socio-political barriers. It's not a technical barrier. And people people aren't getting treated who could get treated. And that always kind of demotivates me when I think about it in that context. That's
one, I suppose, more question for me, just because I noticed in one of your slides you spoke to, there was a number of medical devices, I think seeking approval in the US, like AI/ML devices. I guess when can we expect to see anything similar in the Irish market, or like do things come from the US in that way? Yeah.
So typically they will be approved in the US. That'll be the first hurdle, and once they're validated, then they'll be going to the European regulatory market. And they are. There's hundreds of devices that are being approved. All the main providers of like mainly hardware and infrastructure in hospitals. So like if you have a CAT scan machine or MRI machine, they will have very sophisticated AI models or assistants built in already. They're just not being widely used because the staff might be trained with them or the provider might want to push them. Now that again, that can be an issue of the Hoover problem, whereby they're making so much money off the bags, they don't want to automate the analysis, you know. But there already are some available, they're just not widely adopted or widely utilized. That requires a change of practice locally as well. But yeah, I mean, like say for instance, I visited Sick Kids Hospital in Toronto, and I mean, I hope that our children's hospital is similar when it gets opened, because like that was just mind-blowing in terms of they are pulling all the data 24/7. It's all stored electronically. It's paperless, so like everything's kind of like electronic, which is pros and cons. I mean, there are valid reasons to have paper, but I mean, in terms of the healthcare provided, it was like top notch, and I would love to see that kind of infrastructure for Irish children, particularly.
Perfect. So I think that's all the questions, unless anyone wants to get any in last minute. Yeah, great. Thank you for your time today, Ruairí, and for presenting to us. That was very useful.
Thanks very much.
Thanks, everybody.
Happy to be here. All the best.
Bye.